Okay, so good morning, everyone. Welcome to the FNNDSC talk this morning. So it's my pleasure to introduce our speaker today is Dr. Tai-Wei Wu, and Dr. Wu is a attending neonatologist as well as the director of the neuroprotection program in Fetal and Neonatal Institute Division of Neonatology, Children's Hospital, Los Angeles. And he is also the assistant professor in the Department of Pediatrics at Keck School of Medicine, University, Southern California. So Dr. Wu's interest is in the area of neonatal brain injury and hemodynamics. So he studies complex hemodynamics change in newborn undergoing therapeutic hypothermia for HIE. His work involved in use many of the technology, including the MRI as well as the NIRS. And so we share a very common interest in terms of our research. And today, so he's going to give us the talk about his research. So let's welcome him.
Thank you. I'm happy to be here, and thanks for allowing me to talk about my research study and interest. Let's see. Next slide. I have no conflict of interest to disclose. Part of the presentation is supported by private funding mechanisms such as Gerber Foundation, Rudy Schulte Research Foundation, and a Reiling Family Foundation. The presentation is really broken up to two sections and probably reflects more of a primary role as a clinician and also the resources that are available to me in answering questions of clinical interest. The first part, we'll discuss cardiovascular changes in infants undergoing cooling. This is investigated by the use of interval and continuous bedside physiological monitoring tools. And the second part, will be a shift of gears to looking at how we use MRI to measure brain temperature and cerebral metabolites at two distinct time points. Okay. Now, just a little background on HIE, as I believe everyone here is familiar with the disease. It's a fetal or newborn brain injury secondary to cerebral hypoxia or ischemia. The incidence is estimated to be about 2 to 6 per 1,000 live births. It can lead to significant developmental morbidity and mortality. And the standard neuroprotective strategy is cooling for 72 hours. This only modestly reduces morbidity and mortality. When I say modest improvement, and that's because even with cooling, about 30 to 40% of newborns with HIE will still die or have moderate severe disability. Now, what's next? There are a number of clinical trials that focus on adjunctive therapy on top of cooling, and this includes and are not limited to xenon gas, melatonin, stem cells, extracellular vesicles, the medium, EPO, cannabinoids, azithromycin. There's some vitamin candidates out there, and even hyperbaric oxygen. And as a fellow in training in 2010, I was, intrigued by more of temperature as a physical property and how it's regulated tightly in life forms. Just perplexed at how, mammals invest so much energy, they modify their behavior and develop, complex physiological mechanism to maintain a core temperature. And so I was kind of stuck with cooling. I didn't move on forward to sort of adjunctive therapies for HIE. Wanted to understand a little bit more about this thermal modulation therapy. Do we know enough about it? Are there opportunities for further optimizing cooling? What are the hemodynamic effects of cooling, both systemically and at the organ level? And how cold is this target organ, the brain? Is brain temperature kind of homogeneous throughout the brain, or are all regions equally cooled? And what's the impact of having different brain temperatures on cerebral metabolites? And so this brings us to the first section, which is really about cardiovascular hemodynamic changes during cooling. The cardiovascular complications in HIE, can be kind of divided or described as follows. First, the effects of hypoxic injury. You can see about 30% of these infants of HIE will suffer from myocardial dysfunction with a depressed cardiac output, hypotension, and sometimes even from pulmonary hypertension. In addition, the effects of cooling, so the treatment side, you can have peripheral vasoconstriction, increased vascular resistance, and an increase in blood pressure. And overall, through the clinical trials, they are reporting 33 to 77% experience hemodynamic instability. And that's defined roughly with experience of hypotension or pulmonary hypertension. This is a graph that shows Doppler velocity in 47 infants of HIE and 37 healthy newborns. They did not, this is sort of pre-cooling era, so this is without the effects of therapeutic hypothermia. The graph is, depicts the basilar artery velocity, and it's measured, through time. The white bar represents normal infants without HIE, and the gray bars are mild, moderate HIE, and the black bars are the severe HIEs. You can see that in the normal and mild HIEs, the basilar arteries velocities are pretty stable throughout, and then kind of slowly takes off at the third week of life. On the other end, the severe HIE babies, there's significantly higher velocity more acutely, and then it kind of falls down with time. So this might be related to the phenomenon of this luxury perfusion secondary to vasoparalysis of the cerebral vasculature after severe injury, but that's speculation. This is a pilot study from Dr. Shankaran that is really just 19 patients comparing what the heart rate does during cooling. So during normothermia, heart rate's a little bit higher, and it is decreased in the hypothermia group during the trial. And that's probably related to the physiological response to cold, depression of the neuronal firing of the SA node. This is the same study that shows blood pressure is comparable between cool and normothermic group, and this is by Dr. Shankaran as well. By Whitelaw et al. Shows that the blood pressure increases during cooling and decreases during rewarming. So small numbers, and really just taking a peek at what happens, and a rough look at what happens to heart rate and blood pressure during this cooling period. This is a piglet study with HIE that underwent cooling, and they had performed echocardiography to measure cardiac output. And there you can see a little spike at the 3-hour mark after the hypoxic-ischemic insult, and that falls down to lower levels thereafter. So there is no difference in stroke volume between the cooled group and the hypothermia group. So essentially implies that there is no changes between cooling and non-cooling. This is the tricuspid regurgitation measurement, which is a surrogate measure for pulmonary arterial pressure. It's similar to cardiac output in the result side, where it up spikes at about 3-hour mark and then decreases thereafter. Again, these are very small numbers. This is looking at cardiac output in human neonates with HIE during rewarming, and it's stepwise increase as we would expect. There's only 7 patients studied. One important caveat to the study is that 4 of these patients had dobutamine infusions. So dobutamine is a inotrope, and certainly it would increase cardiac output, and it would increase the contractility side. So as part of this, it might be contributed to or from the pharmacological influence itself. And so in summary, during fellowship, I felt like, well, this is not that well studied, and I was interested in understanding what the relationship is between all these variables. It seems like there's conflicting results. There is, I think, slam dunk, we know that there's a decrease in heart rate, maybe no change in blood pressure. And is there a maintenance or decrease in cardiac output? Is there an increase in pulmonary vascular resistance? All these things kind of tied together led to my fellowship project. And it reminded me of a parable of the three blind men and the elephant that's depicted in this comic. So each study was pretty much focused on their favorite variable and told its own story, but I really wanted to see more of a comprehensive look and explain the changes that were occurring simultaneously. Now, how did the change relate to each other? Another question in mind is what happened to the cerebral circulation during rewarming as the cardiac output would go up? What happened to the blood pressure and if the cerebral autoregulation was in place or not. For the study, we utilized conventional cardiovascular measures such as heart rate, blood pressure monitoring. All the infants did have arterial lines. We had used echocardiography to look at the heart as a systemic pump, and then also measured Doppler velocity in the cerebral or middle cerebral artery side. We utilized NIRS, which your group is more familiar than I am, with its limitations as well. And then we also used impedance cardiometry, which allows for continuous cardiac output monitoring. I'm not sure if your group uses impedance cardiometry at all, but this is essentially calculating cardiac output based on changes in impedance secondary to red blood cell ejection during systole and how the red blood cells kind of line up during systole, and so the impedance is lower. And during diastole, the red blood cells kind of settle out and the impedance increases. So there's a lot of assumptions there, and through complex algorithms, spits out a cardiac output continuously. This was the research design. I think before we jump into results, better to understand what was done. We had continuous measures of NIRS, ICON, and vital signs and amplitude EEG. They were fed into either of the two systems, Vital Sync or Bernoulli system. They try to, the goal here is to time sync all the data. It's not very high resolution. It's about every 5 seconds a data is logged. With the Bernoulli system, I think the raw data allows us to look at true waveforms. But for the user-friendly version, we only get the per 5 second data. We documented the pressor inotrope medication changes, the ventilator changes, and if there were any seizures throughout the monitoring period. And the period of monitoring is a total of 11 hours. The initial 4 hours is during cooling. There's steady state during cooling. And then during the rewarming, we see this as sort of a dynamic phase when temperatures ticked upwards, 0.5 degrees every hour. And then, we had, monitored until 1 hour out after rewarming as another steady state. The arrows at the bottom denotes when we obtained the echoes and the MCA Doppler flow measurements. And so the results, we had 20 patients enrolled at that time. I think we're up to 26 now. The gestational age is mostly term, a good weight for most babies. Majority of them had moderate encephalopathy, only 3 was severe. And the APGARs and the pH show that they did need resuscitation, and they were pretty acidotic at birth. This is just a sampled raw data for one patient. The x-axis is time, as we had talked about, the 4-hour baseline, the 6-hour rewarming, and 1 hour post-rewarming. The mean blood pressure is denoted in gray circle. The oxygen is in light blue, heart rate in green. The cerebral NIRS is in brown, and the renal SO2 is in, that's a pretty dark gray. And the cardiac output is right here in measured by the impedance cardiometry. And you can see that the cardiac output and the heart rate kind of goes in a similar direction. They increase for rewarming. And down here with the blood pressure, the light gray wave, you can kind of see it mirror with the renal SO2. And we'll talk about this towards the end of this section and what that really means. So this slide, talks about how we assess the pump. What does the heart do when it's cold? The heart rate, during rewarming is increased, and the fractional shortening, or how well the heart squeezes, is also improved during rewarming. But there was no change in stroke volume. So the increase, or the strength of the contractions did not translate to any increase in stroke volume. This slide shows the total amount of blood that's pumped out per minute, and it's a measure of volume over time. And naturally, lower heart rate translates to a lower cardiac output. And with the rise in heart rate, there's a rise in cardiac output. It's similar between the echo findings measurements and the impedance cardiometry measurements. So this is no surprise. Now, what was the effect of that 20-30% increase in cardiac output during rewarming? Did it translate to higher blood pressures? By using Ohm's law of fluid dynamics, we see that change in pressure equals flow times resistance, or P equals Q times R. And this can be applied to our cardiovascular system. And from there, we can derive systemic vascular resistance. And so we see that through rewarming, seems like there is a lowered or decreasing SVR, likely from just peripheral vasodilatation. The mean blood pressure pretty much stayed the same until the end of rewarming, and there was a slight significant decrease in blood pressure by the end of rewarming. So in summary, at the cardiac and systemic level, during rewarming, the heart rate is increased, fraction of shortening is increased. We don't know the preload status, but stroke volume was unchanged. At the systemic level, cardiac output is increased, most likely from a heart rate augmentation, and SVR is decreased, leading to a mildly decreased blood pressure. Now let's move on towards the sort of organ level. I think this is perhaps more interesting. From the middle cerebral artery Doppler, we saw an increase in peak systolic velocity. This is perhaps related to the decrease in vascular resistance, or the vasodilatation of the MCA. This is appreciated qualitatively, but it's difficult to measure. I mean, as the babies were rewarming and I'm echoing them, or doing the Dopplers, I can see that it's so much easier to make these measurements, because the MCA diameter has increased so much with rewarming. So it was always an easier time for me at the bedside towards the end of rewarming to get these measurements. But it's difficult to measure them quantitatively in terms of MCA diameter, just because of the errors. It's very error prone. So we didn't make any quantitative measurements about MCA diameter, but I think we're inferring that this uptick of peak systolic velocity is secondary to vasodilatation. And so looking at NIRS and the plots of tissue oxygenation at the brain and kidney level, the top curve in each graph is the CRSO2 or RRSO2, renal SO2. The bottom curve is the fractional oxygen extraction. So we can see that in the brain level, there's no change in CRSO2 or at the fractional extraction level, oxygen extraction level. In the kidney side, you can see that RRSO2 did increase with rewarming, and the tissue extraction there seems to be decreased with rewarming. And this is the ratio. So once you try to relate both cerebral and renal NIRS, you can easily pan out this renal to cerebral tissue oxygen ratio. Normal ratio is usually in healthy term babies should be around 1 or even greater than 1. It kind of illustrates the balanced flow or oxygenation in both organs. You can see during cooling that this renal to cerebral tissue oxygen ratio is lower, less than 1, and this increases to more normality, more normal levels once rewarming is complete. And so this is perhaps what's happening, and in normothermia with a normal heart rate and cardiac output about 250 per minute, there is a balanced blood flow to both vital and non-vital organs. And in hypothermia, the heart rate is depressed, and there is no compensatory increase in stroke volume, as we saw, to counter this SA node depression. The cardiac output is low normal, about 150. And there is preferential blood flow to vital organs. This is reversed with rewarming. So clinically, this could be especially important to those with acute renal injury, usually the ones with more severe hypoxic-ischemic injury. And it's unclear if sacrificing flow to non-vital organs to save brain would contribute to overall mortality, especially during the deeper and prolonged hypothermia trials. So in summary, at the end organ level, cerebral metabolism implied to be increased without changes in CRSO2, with an increase in MCA peak systolic velocity, and that kind of suggests maintenance of the flow metabolism coupling. There is redistribution of blood flow to more normal levels where both kidneys and brain reach more a shared distribution of blood flow after rewarming. So in conclusion, non-vital organ blood flow may be decreased during hypothermia therapy, and cerebral blood flow and autoregulation appears to be intact during the rewarming phase of hypothermia therapy. And so we really don't know if this is, this relative decrease in cardiac output during cooling is, injurious or protective. We know that deeper and more prolonged cooling with the clinical trial has led to higher mortality and was stopped early. And so we kind of question if we improve the cardiac output or end organ perfusion, would that reduce mortality? Would that, play in any sort of benefit? Can we better tolerate deeper hypothermia once organ blood flow is augmented? And that's probably a difficult question to answer, given the early stoppage of that clinical trial. There were some interest, I think, from the Stanford side to trial theophylline for renal protection. But theophylline is also great for heart rate augmentation. I think it'll help boost the cardiac output as well. And end of the day, we just don't know if that's, injurious, does that worsen the reperfusion injury, or if that's protective for the other non-vital organs. Now we can circle back to what I had mentioned earlier in the presentation regarding blood pressure and the renal SO2. We saw this waveform that kind of mirrors each other, and that's the gray and the dark gray. If you look long enough at it, you kind of see this mirroring image, and that's what I did. I looked at these curves a lot, and so maybe a little bit more obvious here with the one patient. We'll see a few examples of individual tracings. The red curve here is now the mean blood pressure, and the orange curve is renal SO2. The x-axis is time, of course, and the 0 and the x-axis marks when rewarming was started. So maybe not so obvious here, but you could see a little bit of curve here, and it mirrors with the mean blood pressure. This may be a little bit more obvious. The orange and the red seems to mirror each other, especially here. And you can see that kind of throughout rewarming. And the interesting thing about this patient too is that there was sort of a close resemblance between cerebral and renal nears throughout. And at the completion of rewarming, as cardiac output took off, you could see cerebral nears kind of plateau in the 90-95 range. So what does this all mean? We'll look at a few more individual tracings. And here it's, I think no doubt to say that there is mirroring. between the renal nears and mean blood pressure. And these blood pressure waves are in the magnitude of maybe, 1 per hour. And so these are very low frequency blood pressure up and downs or waves. And you could see that with rewarming, you could see, numbers kind of float upwards, but the mirroring is still in place. This is a patient that passed away and was on dopamine perfusion. You can see there is any sort of mirroring in this patient. If anything, it's probably pressure passive. This is another patient with, the waves and the mirroring, just for your appreciation. And then the last patient here, you can see sort of this rapid upswing and slow downswing of blood pressure waves. Goes up quickly and slowly comes down, goes up quickly, slowly comes down. And the renal nearest kind of tries, you can see it mirror that also with the heart rates as well. So this isn't new. This was seen in the 90s already with blood pressure changes. This seems like every 40 minutes or so, there's a uptick of blood pressure, and it mirrors the heart rate. And this is another example. It was published in 94. Now, this is also a rapid upswing of blood pressure and a slow downswing, rapid upswing, slow downswing. And I don't know what this really means. And I've shown IV this before, and just a physiological phenomenon, I think, perhaps related to the autonomic system. And it's probably more of a physiological question than, for it to have any sort of clinical impact. It's probably too elaborate to say, hey, you have a loss of, renal response to blood pressure, and so that's poor prognosis. It's probably easier to look at the patient clinically with neuro exams, clinical course, and an MRI than to look at this and try to prognosticate this way. So now we'll shift gears to the second part of the presentation and really studying the effects of cooling on brain temperature and cerebral metabolites. As you may know, the cooling down to 33.5 degrees is for 72 hours, and it's servo controlled based on a core temperature of either rectal or esophageal probe. And, this is just a slide that simplifies the concept of brain temperature, sort of in a confined space. Brain temperature is a product of heat generation through cerebral metabolic rate, baseline metabolism, and heat dissipation by, the cerebral blood flow and the surrounding physical environment. So upon literature review, we can seem to agree that deep brain is warmer than superficial brain, and that the brain temperature can be higher than body temperature by about 1 degree, and this is called brain-body temperature gradient. The brain can fatigue from overheating, and there is a cognitive decline and short-term impairment when cooled. So these are more results stemming from national defense or military studies that try to see what happens to the soldiers when they're in the cold. In pathological states such as stroke and traumatic brain injury, brain temperature can be drastically elevated, not all the time, but this is associated with poor outcome. Medications, analgesics can also alter brain temperature. I think that probably works from the metabolic standpoint. So this is just superimposing, multivoxel MRS, measuring brain temperature over an area of stroke. You can see that area is more in the yellow-orange zone where, the stroke is, could be warmer than the rest of the brain. So we aim to investigate brain temperature during cooling by MR thermometry. And this presentation was geared more towards a clinical audience, but I'm sure your lab, knows the MR spectroscopy better than I do. But temperature affects the water peak, the shifting of the water peak. And through measuring the frequency difference between water peak and the other metabolic peaks, as the brain tissue, tissue temperature becomes warmer, the H2O peak shifts towards the other metabolites. And when the brain is cool, it shifts away from it. And so knowing sort of the theoretical concept, I kind of went to test this in a phantom experiment. So I heated up a brain phantom, that was filled with NAA, creatine, and choline. And then I heated this phantom to about 50 degrees Celsius outside the MR suite, of course. And then when it's heated to 50 degrees, I put in the MR temperature probe in the MR scanner, and I scanned it every 3 minutes as the temperature fell from 50 degrees to 25 degrees. And from there, we could derive a calibration curve, which is on the right-hand side, based on the frequency difference between water peak and the other metabolites. And so we can see that every few minutes, I was obtaining a measurement of MR spectroscopy, looking at the frequency change, and deriving a formula too. So this essentially acts like a ruler. What's your frequency difference between water and metabolite peaks can give you tissue temperature. And this is my brain. I tried it on myself just to see what my brain temperature was as a test. And of course, there's no true standard here. I didn't have an invasive probe to measure my brain temperature to know, but it seemed reasonable that my temperature was 37.1. This was later also, I say, validated crudely, perhaps, using another brain phantom and also on different patients by another group, I think in Norway. And so this is how we brought patients down in a controlled fashion. There was no compromise in active cooling. We had servo-controlled cooling throughout the transport, throughout the MR scan, and upon return to the NICU. And so there was always a temperature probe so that we could measure or monitor the rectal temperature continuously, so that we would have to abort if we had any inadvertent overcooling or rewarming. That would just be disastrous. But we've gone through about 64 patients so far, and we had not had any incidences, knock on wood, unfortunately. This was just a short publication in 2014 that looked at the rectal temperature as we brought these patients down to show proof of concept and that this was safe. And that all the patients remain within the target therapeutic temperature. So the study design is quite simple, is really obtaining MR spectroscopy and conventional MRI sequences during cooling and after cooling. They were all scanned in the same 3T scanner. There was a Philips scanner, and the region of interest are going to be shown on the next slide. The important thing is that the rectal temperature was measured, throughout the MR scan, and we could link this back to the brain temperature. I think it's quite useless to just only get brain temperature and not understand what the rectal temperature was doing at the same time. So we measured regional brain temperature for the following areas: the left thalamus, the right basal ganglia, cortical gray matter, and the white matter. And this was just a sample raw MRS data on the left-hand side, showing, the blue is when the patient is cold and during hypothermia, and red, that shift in water peak, as you appreciate, is when the patient's rewarmed. So our preliminary findings were, published at Journal of Pediatrics, just to illustrate that brain temperature can be higher than rectal temperature, and that doesn't correspond to core temperature sometimes. So on the left-hand side of the graph is when during cooling, when the patient's cooled, and the top is brain temperature, the bottom is rectal temperature. we can start with, when they're cooled, you can see that their rectal temperatures are pretty, narrow and well maintained. But their brain temperature, if you look at the gray, darker box, is severe HIE, tend to be higher, significantly higher than those with moderate HIE. And this kind of difference is maintained even after rewarming is complete. You can still see a higher brain temperature, sometimes in the 38, 39 degrees Celsius, and that the rectal temperature is also comparable without difference. And this, again, that time we only had 18 patients, and only 4 was severe. And so having both the rectal temperature and brain temperature allows us to, calculate this gradient. What's the difference between the target organ and core temperature surrogate? And we can see that for the moderate HIE patients, there's not much difference between the brain and the rectal temperature. And for the severe patients, that degree of difference can be as much as, even 3 degrees Celsius difference. And during rewarming, this relationship was maintained, and that there was a higher brain temperature than rectal temperature in the severe patients. Now, with more patients, and that was based on sort of neurological exam, how they presented in terms of moderate versus severe HIE on admission. But with more patients, we try to relate this to injury severity on MRI. And this is somewhat of a rough read, because this is based on the Barkovich reading scoring scale. And so those with normal reads with N about 30 had brain temperature during cooling of this range. And there was a difference for those with severe injury, and seeing that, hey, there are a subcohort of patients. Sorry, it keeps moving. There's a subcohort of patients that does have a pretty elevated brain temperature despite their rectal temperature being adequately cooled. And this was published last year. This is not published data, and we're working to get this out, is the outcome. So we kind of looked at how this relates to MRI injury, severity of MRI injury, and how does this even translate to outcome. We see that there is a difference only during cooling for the good versus poor outcome group. Poor outcome is defined as Bailey less than 70, cerebral palsy, or death at 2 years of age. There was 56 patients, and we only saw a difference in brain temperature during cooling between the two groups. So in conclusion, some injured brains are resistant to cooling perhaps, and a higher brain temperature associated with more severely injured brain. Further questions include, will deeper cooling improve outcome for this subset of patients? There was a clinical trial that looked at deeper and more prolonged cooling, and that was stopped early because of higher mortality rates. But I think that was applied to a full set of patients that may not need a deeper cooling. Are there particular regions of the brain that's more resistant to cooling? And so this is a thermal map of healthy primate brain, and looking at the different numbers here is really how does it compare with arterial blood temperature. And we can see that it seems to be warmer in the center of the brain, and as you get to more periphery, the brain becomes cooler. And this is by invasive temperature probe measurements. As they pulled it out from the macaque brain, they saw a lower brain temperature in the more superficial side. And this is Abbott Laptook's study in 2001 that looked at brain temperature during selective and whole body cooling in piglets. You could also appreciate here that this is during whole body cooling, that deep brain is slightly warmer than superficial brain. Another study by Iwata in 2006, and again, also piglets HIE model undergoing whole body cooling. This is temperature measures. The small letters here denote how deep they inserted the temperature probes. And through here, you can see the deeper they are, the warmer the brain is. And just by very small measures, sometimes by less than 1 degree difference. So we went in thinking, well, our hypothesis would be that the core, the middle of the brain where, basal ganglia is usually hit in HIE is perhaps warmer than peripheral brain. Is this warmer brain temperature we see, is that more of the basal ganglia side, or is it somewhere else? And so we retrospectively measured depth of voxels and correlated temperature of depth of tissue. We had 46 patients at that time. And this is the voxel depths, sort of going through different slices and measuring the closest distance to the skull. And this is the depth measurements for thalamus voxel. Is about 35 millimeters, and basal ganglia is about 30 millimeters, and the gray matter, white matter voxels is about 20 millimeters. And these were the temperature measurements at different depths. You could see that there is a stepwise pattern from deep brain to superficial brain. It's a little different from what we expected, actually reverse of what we had hypothesized. So deep brain was warmer than superficial brain. And is this really what's happening? I mean, is this real that, we see that in normal physiology, the core of the brain is usually warmer, and in neonatal HIE with whole body cooling, we have effective cooling of this area in the core of the brain. And this is different from the piglet studies as well. Could this be a size of the brain itself and the way the environment shelters or dissipates heat? Or would this be effective cooling of core structures? Or is this more of a ischemic core penumbra effect? Is the area injured more at the core, and you have mitochondrial dysfunction and exhibiting lower metabolic function, and hence a lower temperature there, just much like adult stroke, the center of the stroke is usually colder. So in conclusion, with a lot of reservation, we conclude that the brain temperature is non-uniform during cooling, and that peripheral regions appear to be warmer than core regions. The implications of this, can a more uniform cooling improve outcomes? We really don't know. This would probably be technically difficult to implement. And from lab studies, we kind of know that different types of brain cells can have different timelines for apoptosis and repair. Does this mean that optimization of cooling requires different temperatures and durations at different regions? It just becomes quite complex and difficult to apply in the clinical setting. Now I'll quickly go through sort of the, now that we have, brain temperatures are higher and lower in the brain, different areas, wanted to see how does that relate to the metabolite concentrations. It's a very small, regional difference in brain temperature, just about 1 to 2 degrees difference. Could there be a metabolic impact? So we aim to determine the relationship between brain temperature and selective brain metabolites. And we hypothesize that higher brain temperature associated with lower cellular energy levels and increased neurotransmission and neurotoxicity. These were the serum metabolites that we looked at, phosphocreatine and free creatine, which is a rough surrogate measure for the cellular energy state. We couldn't get ATP because that would require a phosphorus coil. And this is all proton MRS. We looked at total choline levels, NAA, and glutamate. And this is part of statistical analysis, which is quite straightforward. So we had 76 infants undergoing, therapeutic hypothermia. And we analyzed more than 500 MR spectra. This is unpublished data, but was presented at PAS last year and also at the Brain Conference last year, where I met Ivy as well. And you could see that, where there's significant correlation is in the phosphocreatine and total creatine areas. Sorry, this is free creatine areas. So there is significant correlation in the energy status in the total choline and the glutamate levels. And we'll look at these closely in a graph form. But interestingly, lactate, there is no difference, no correlation between brain temperature and lactate, and no difference in NAA as well. So looking at the phosphocreatine and free creatine as a surrogate measure for cellular energy reserve, we saw that with increasing temperature, brain temperature, there was a drop in phosphocreatine and an increase in free creatine. And that really just kind of shows you the equation is pushed to the left with warm brain tissue, and that denotes a lower energy reserve. And this is total choline as brain temperature increased. Total choline, or this marker for membrane metabolism, is increased. And lastly, glutamate, which is, again, a very remote marker for neurotransmission and perhaps neurotoxicity. It's increased when brain temperature is warmer. So in summary, the results illustrate that small changes in brain temperature are associated with metabolic changes specific to cellular energy reserve, membrane turnover, neurotransmission, and all the brain regions investigated. And so deeper and more prolonged cooling has been shown to increase mortality, but the effects of more homogeneous brain cooling has not been investigated. So in summary, I think I'll wrap up and see if there are any questions. Although therapeutic hypothermia does confer modest neuroprotection, still 40% suffer from death or severe disability. Brain temperature is above rectal temperature in some patients, especially those of severe injury. The peripheral or outside of the brain or outer areas of the brain may be warmer than core regions during whole body cooling. Small changes in that brain temperature is associated with alterations in the metabolic profiles, suggestive of neurotoxicity, energy failure, and membrane breakdown. And acknowledging my mentors and colleagues, and of course the families that really trusted us to bring their child down to the MRI during cooling. Really thankful for them. And with that, I'll see if there's any questions, and happy to discuss anything.
Great, thank you. That was an amazing talk, extremely interesting and very close to what we're doing. So it's really exciting to see your work.